All right, everybody. We're back again for another wonderful episode of our Down Fracture podcast, a podcast for talking jaws. As is custom, this is Dr. Michael Wasson of Arizona Jaw Surgery here with Dr. Sam Bobek of Seattle Jaw Surgery. How's it going, Sam?
Good, Mike. Happy Monday.
Is there such a thing? Well, we've kind of hit some milestones on the podcast as we've been telling people recent weeks or episodes that we have an email now, downfracturepodcast at gmail.com and encouraging people to reach out and submit questions, topics, cases, etc. And we got our first I would guess I would say, we get a lot of fan mail, but we got our first like legitimate email question. And it was a good one, I thought. What'd you think?
Yeah, I mean, it was very positive, I thought, because it came from a resident who has interest in this world, which that premise itself gives me hope. Because part of the reason for us doing this is just to kind of keep the interest on these topics, because it's very oral surgery. It's very interesting stuff. So I like just the idea that there's residents interested in this sort of thing.
Yeah. And then you had a personal milestone this week, right? Where platinum status and hair club for men. Was that what it was?
Yeah, no, I think my hairline, my forehead's just growing. It's kind of just one of those things. It's like ears, right? They keep growing forever. Uh
Yeah, you so
no,
all right.
yeah, no, I mean I don't think I had any other milestones. I think
Okay.
I could think of.
I mean,
But yeah,
that's
I
a
think
big enough one.
the issue that came up in terms of the question had to do with modified condylar osteotomy. And so
In the
I
treatment of TMJ
in the
disease.
yeah, exactly. So and it was proposed as an intervention, which it definitely is. I just don't personally have a ton of experience with it. And so I favor shelving the topic until we can get someone on who does that more regularly. Because where that fits into the overall treatment, I think your opinion was in a malocclusion, like a class 3 malocclusion with an internal derangement. But I do believe there's other interventions that might make sense or I'm sorry, other situations where it might make sense.
Right.
So I was gonna shelve it a little bit until we can get someone on to give us some tips on that because I think we could both use it.
Yeah, we could definitely learn because it's not something we do in volume. And yeah,
Yeah,
I would echo
definitely.
your sentiments. I was glad to receive an email. I thought it was an interesting question. I do think it has uses, but as we talked about, I guess was it last week or yeah, last week when you're trained arthroscopically, I think that tends to be your workhorse for that same situation. But if you said, hey, I'm not arthroscopically trained and my options are open joint surgery, which as you pointed out last time, leads to scarring of the joint and other things, you could say, hey, well, an extra capsular procedure may have some merit and value. And so I think there's an avenue there. But yeah, okay, well, we'll shelve that. But yes, thank you for the email. Again, that's downfracturepodcast at gmail.com. If there's any other questions, topics you guys want to address. And yes, keep the fan mail coming. So what are we going to talk about today?
I thought the topic was going to be condylar hyperplasia. Sticking somewhat to the TMJ theme that we've been at for a little bit of time here. Condylar hyperplasia is a good overlap and a good bridge between the worlds of orthognathic surgery and TMJ surgery. What do you think?
Agreed. Yeah, agreed. I almost would liken it to the opposite of like ICR. Like there's a lot of overlap potentially there, and there's a lot of overlap here in the opposite kind of
Definitely.
manner.
Yeah, because it's confusing. What's going on with the joints in terms of what's the origin of the malocclusion? Because you will meet people with progressive malocclusions. And figuring out if it's a resorptive process or an additive process is a very simple initial thoughts going through your head when you meet somebody. Because that's a better thought than panic. I don't do TMJ. I'm going to send them over to someone else. I think thinking about figuring out what the source of the trouble is correct. So understanding the additive process or one of the additive processes is a good topic.
Absolutely. Yeah. So why don't you walk us through how you go about doing that? Because I think conceptually it's easy. Okay. There's asymmetry, or asymmetric growth or resorption here. and fundamentally, I think that's an easy thing to conceptualize, but I find that diagnosing this at times can be challenging because I've also met people without asymmetry who you look at their condyles and you just say, wow, both of those don't look atypical, but one is significantly larger than the other, and you're fine. So I think it can be, a little bit of a challenge sometimes, and then you got to figure out if it's ongoing or if it's historical, right?
I agree. Yeah, no, I mean it's when you get into this, it becomes a bit trickier. But I think generally in terms of condylar hyperplasia, it is a progressive asymmetry either to the part of the mandible or the entirety of the mandible. I think the first initial discussion has to do with like how you classify those things, and there's different classification systems. I guess I've always kind of been drawn to the Obergeiser classification in that the spectrum is hemimandibular hyperplasia or hypertrophy, depending on what you read, versus hemimandibular elongation or condylar elongation. And the most common type is a mix of those two. But if you think of the two spectrum on either end, where elongation causes the chin to go away from the side of overgrowth, the teeth point towards the condyle that's overgrowth. There's a midline discrepancy, tends to be class 3, kind of a mandible condylar neck that's long. Just it looks longer than the other side, and the chin is pushing away from that. So versus condylar or hemimandibular hyperplasia, which is one side of the mandible is just large. That's the
Mhm.
big condyle. It's a bit of an osteophyte sometimes present in the anterior part. Just looks bigger than the fossa. Inferior border bows down. There's a ipsilateral open bite. Midline may or may not be off. I think classically it's on. And that like that picture in terms of the very classic on either end of the spectrum is useful because most people fall in the middle of that, right? Like they have an inferior border bowing, but their midline's off and
Right.
the condyle may or may not look too bad. But I think in terms of characterizing them, to me, I like that better than other characterization systems because I have heard of others. You mentioned one, I think, when we were talking about this ahead of time that
Yeah.
you use clinically.
I know I'm kind of similar to you. Is I think I tend to be more descriptive or defining the problem than I am classifying it. But the other one out there is the Wolford system, and I tried to pull up a paper that I just had saved here to review it a little bit because I remembered the basics of it, and that is that type 1 is kind of what you're talking about or defining as condylar hyperplasia or condylar overgrowth, long neck, condyle. 2 is an osteochondroma, benign tumor of the condyle. And then 3, what are you smirking at me for? I see your
Well, no,
face
I
twitching.
just the problem with this classification for me at least is it speaks generally of overgrowth of the condyle rather than specifically in the persistently growing condyle from adolescence, which I perceive that to be condylar hyperplasia. Um,
It seems
because
like an
like an osteo
unnecessary classification to an extent. Like either you have a tumor, and then I think what 3 and 4 are other versions of tumors. Like 3 is other versions of benign tumor, other rare benign tumors, and 4 is malignant
yeah,
tumors.
exactly. Malignant tumor is part of that classification system,
Yeah, so like
which is
that seems
it's
a little
very
unusual.
like that couldn't be any more different in terms of
Right.
management strategies because like sarcomas of the condyle but I think osteochondroma, what's osteochondroma versus what's condylar hyperplasia, I think largely it has to do with age and kind of how it looks clinically. Because I think we meet people in their 60s and 70s with progressive malocclusions, and high on your list should be cancer. Ruling out a malignancy versus an osteochondroma seems to be a better approach than it is in a progressively asymmetric 17-year-old, right? And
Mhm.
or 25-year-old. It's not like you shouldn't forget about bad stuff. It's just the likelihood of that is much less. And so that's why I think when at least in my mind, condylar hyperplasia is more of a disease of like 20-year-olds, maybe late teens, maybe early 30s, but it's kind of like young adulthood. Um,
Late adolescence, early adulthood.
yeah,
Yeah.
in that world, I think that describes those different ways. So I don't know. I think
Would your management be different? Like, let's say you couldn't differentiate between those two.
Because yeah, that's the other thing is it probably wouldn't be any different anyway. Because the surgical management of that situation is largely the same. It's just timing and how you talk to family, I think, is important. So um, I think that when it comes to the classification system, I think I use those two ends of the spectrum. But when I meet people, usually it's before they started braces, and um, like when you talk to them, does it the questions that come up is, do we need to do condylectomy or not? How do we know if this is actively growing? And what I would propose is you don't need to know at the consult. I think one of the key things when I'm talking to people for orthognathic surgery is kind of finding out what's driving them, telling them generally about surgery, coming up with a diagnosis, working on insurance, helping drive orthodontics. I think if you're not suspicious for more worrisome things in the joint, and it looks to be one of the classic like condylar um, hyperplasia variants, then seeing how they progress is correct. And they can wait on orthodontics or proceed. It's an easier decision when they're in their late 20s, but serial bone scans and that sort of thing, I don't like. I just like talking to them and then discussing that at the recall visit. Do you
You don't,
typically?
you don't have, yeah, I mean, the other situation you mentioned, you often see these patients prior to orthodontic treatment. And maybe what I'm going to say, another scenario where I see them is kind of like that, where you're seeing them for a consultation. Um, and a lot of times, someone recently where patient was about to start like their fourth round of orthodontics, like which kind of should raise some red flags for people. It's I had orthodontics as a late childhood, early teens, and then again kind of late, like early teens, mid-teens, and then late teens, early 20s. And every time we were trying to correct this asymmetry and we would get it close, and then a couple of years later it's worse. That's a scenario where I've seen it before. Have you seen that?
Oh, for sure. Yeah, definitely. I
Yeah.
mean, they're just self-diagnosing that the condyles continue to change. Because, I mean, generally, diagnosis at the beginning, making sure you're not dealing with something worse, and then coming up with a strategy. I think um, kind of recent literature, recent last 3 to 5 years, um, argues for superimposition of cone beams or CTs over bone scan.
Hmm.
I want to say that's a Houston paper, but I don't know if that's 100%, but I feel like it is.
Is that what you do? Is that how you approach it?
Yeah, so what's nice about the initial consult and you're on the fence of whether or not it's active is you just get a bone scan at the beginning to rule out bad stuff or at least to lessen your suspicion of bad stuff. And then you send them off to orthodontics, see them back, in a year or so, could be less, could be more. And the question is, have they progressed? And, clinically, their midline's off, they have more of an open bite, the condyle looks bigger. That's the time where I historically got bone scans. So technetium 99
Hmm.
bone scans, setting him up to see if it's growing. But nowadays, I like the superimposition of the data sets almost a bit more.
Do you feel like you can do that fairly accurately?
Yes,
Because I mean,
accurately
I think
enough
that's
to see if it's
been,
a few millimeter difference.
I think that's been the argument, or the other, if you want to play devil's advocate here, is how confident are you that you're accurately superimposing things to where, given their rate of growth and the time that's passed, that you would feel confident one way or the other.
Assuming the person is otherwise skeletally mature, right? So we're not arguing about like a 17-year-old male class 3 patient. What we're
Yeah.
talking about is someone who's done with growth otherwise, and you're suspicious clinically that they're growing on their
Yes.
follow-up appointment. That the options in that scenario would be to get a bone scan, to superimpose the data sets, or to just do the condylectomy. And I generally favor nowadays to the cone beam superimposition. I bet you I'm throwing a curveball at you right now. Did you even know this?
You are you are a little bit. I mean, I was aware that these are basically the two ways to go. I was not familiar with the Houston paper that I can recall of, assuming that's where it came from.
Yeah,
But
sure.
yeah, I tend to do the opposite. I tend to bone scan them. Like I want to find out what's going on
Yeah, bone
because
scans are solid. I don't want to hate on bone scans. There is a fair bit of radiation with the bone scan, so there's that. And then what's significant?
I feel
What's
like
your threshold of
radiation.
significance?
How confident are you that radiation is even real? Let me throw a curveball back at you.
I'm
You
pretty
know,
confident it's real. I
we
mean,
throw
isn't
this
the
around a lot of
founder
times,
of
but it's
Radiation Dive anyway?
yeah.
Yeah, we're
Sorry,
gonna
we
get
got off
off.
topic there.
Yeah, definitely conspiracy like lizard people stuff there. Um, no, I think radiation dose is not insignificant when it comes to bone scan. And then
Sure.
the other part is, what's the threshold of difference? I mean, like a 10% absolute difference from side to side, I think is the standard that a lot of people use.
Respect,
Um,
yeah. For
and
uptake,
that, but the
you mean
uptake side,
uptake
yes,
on
it's not
yeah.
like a 45, 55, or I guess that is 10%, 47, 52 or something like that. It would be a significant difference. And so I think either way, whatever you choose to do, I just figure out if the condyle is growing. If it is growing, your options would be to wait or do condylectomy at the same time as jaw surgery. The alternative would be is if it's not growing, then just going on with jaw surgery.
So before we get into treatment options,
Yeah.
let me just back you up here, and I'll give you one of the reasons why I like to do the bone scan early.
Where are you
I
doing the
don't
bone scan at? What time are you doing bone scan?
whenever I first consult on the patient, if I'm suspicious of it, I do it.
Okay.
And part of my reason for this is insurance. I think sometimes I don't see a ton of these. I don't know how many you see. It's all relative, but sometimes I think if you can present the insurance company with the avenue that this is not just orthodontic, orthognathic, um, this is either a tumor, if we're going to say the osteochondroma, if we're lumping that into here too, or benign overgrowth that's ongoing, I feel like that gives you potentially more leverage to treat it as a benign tumor or an overgrowth that you have to surgically arrest and then correct orthognatically and with orthodontics, where even someone who maybe doesn't have orthognathic coverage in their plan may have an avenue for getting jaw surgery similar to
But
obstructive
why
sleep
would you need a
apnea.
bone scan to diagnose that?
You have to prove that you have it and that it's active because otherwise you would just be doing orthognathic surgery. I mean, you
I
could do
mean,
overlays, but I guess that's probably a harder thing to convey to the insurance company.
well, because I mean, the argument to insurance companies is more complicated because you aren't actually making an argument to the insurance company. You're sending them the information that they want to follow their protocols that either approve or don't approve. Because I mean, philosophically, if their condyle is significantly different than the other side and it's causing functional concerns in terms of biting and chewing, jaw surgery is a medically necessary thing. Uh,
They have contract exclusions, and you mean they have to check their boxes.
yeah, yeah.
And I think if you can prove another, yeah, I mean, not everyone has, they have contract exclusions for these cases. So even if they have malocclusions skeletally, that doesn't mean they're going to get approved.
Yeah. I mean, I think considering insurance in terms of if that's the decision at the beginning, I can't argue with that. There's just so much variability with insurance because I mean, I know some in Seattle that cover jaw surgery for TMJ, and then I know some that have TMJ as an exclusion. Like
Right.
they don't cover it if it's a TMJ diagnosis.
So
And
I'm sure we're
so
going to talk insurance one
yeah,
day.
yeah,
So
that's I don't
let's
yeah,
not get into that topic too much. But I mean, I would just say, another feather in your cap to maybe getting something approved, I think may have some value, and we'll leave it at that.
sure.
So,
Yeah, yeah, I'd agree with that.
you started moving on to treatment options and what leads you to go one direction and what those options are. So let's just, for the sake of the millions at home, let's say, so we're not with condylar hyperplasia on our topic here. We're not talking about malignancy. We're not talking about anything, let's just for sake of this discussion, rare or weird.
We're not talking about old
um,
people and osteochondromas. We're not talking about that. We're talking about
okay. True condylar hyperplasia of the condyle, not a
yes,
benign tumor of any sort. Okay. Okay. So let's focus in on that. So you mentioned, and I'll revisit it, the treatment options are orthognathic surgery alone versus condylectomy and
versus a combo.
or the other thing that we discussed the other day with that paper that came out is trying to do some sort of symmetrical condylectomy that doesn't then require an osteotomy to correct the malocclusion, assuming the patient doesn't have corresponding maxillary cant. If they have a
Yep.
cant, then you've bought yourself orthognathic surgery, unless I guess the patient could always refuse. So
Yeah,
I guess we have those. We're going to narrow it down to those three options. Is that Fair?
Well, because I think I heard like four options in there, but it definitely gets confusing here because it's because you know you like read papers or you hear about other people managing these things, and it's like you know what how do you really do this? I think the idea, which is the one that you just talked about in terms of just treating the malocclusion with condylectomy, um, seems wild, but it's out there, and I know people do it.
It is.
So just condylectomy, just jaw surgery and condylectomy. I think there's joint replacement and stuff like that, but let's not, you don't want to,
Yeah.
I won't.
I don't think we, let's not go there for
Yeah. Okay. So
this.
we'll stick to those three then. So yeah, I think there's three. So just
I think
condylectomy, just jaw surgery or a combo.
I mean, I think you bring up a valid argument, or I think TMJR is a total joint replacement is a worthwhile conversation to have with these patients of we're entering your joint, there's something unusual going on, we're going to do our best to fix it. Anytime we do this, it could put you on a path to needing joint replacement in the future. I mean, I have that talk with them,
Yeah.
but
Yeah.
I
Yeah.
don't think we're not going to joint replacement as the primary treatment modality for this. Is that what we're saying here?
I mean, I definitely think that's true.
Okay.
Yeah. I think bringing it up is good just because, for whatever reason, talking about joint surgery at the same time as jaw surgery seems to stress people out a little bit more than traditional jaw surgery stresses them out. And so
No doubt.
understanding that we're not talking to you about the most invasive thing is a good thing to set the argument or set the discussion.
So your preference in this is to do what?
I think I'm a little partial to condylectomy jaw surgery. I think that's my favorite. If I was
So
going
just
to choose,
I'm sorry. I feel like we're jumping around too much, so I want to be clear to the audience. We're talking about at this point in our decision making, we have confirmed that for one way or another, bone scan, overlaying images, we're now confident in a diagnosis of condylar hyperplasia. So we're at that point now, correct?
yep. But I would,
Okay.
of those three interventions, you can use any of them. But what I would say is, um, the clinical exam is a big part of this decision making. I know we were talking about overlay of CT imaging and bone scan as the reasons to do condylectomy. So if it's growing, then you do condylectomy. If it isn't growing, then you don't do condylectomy. I would also just put a little bug in your ear that clinical exam makes a difference as well. Because
Sure.
generally, they don't have internal derangement symptoms that are too problematic, but not always. And so I, I, I think that the final symmetry is better with condylectomy.
The final
And
symmetry is better with condylectomy and orthognathic surgery.
orthognathics, yeah. And
Okay.
I think you have an opportunity to treat internal derangement if there's contour abnormalities of the condyle that could be explaining the internal derangement.
Okay.
So I do think there's a place for condylectomy in a bone scan negative condylar hyperplasia patient, but I don't want to get too much in the weeds in that relatively unusual subset.
Okay. Yeah, because I mean, I do think that's worth mentioning again, since we're seeing that residents and maybe students are listening to this. Usually, these patients don't tend to have internal derangement type symptoms,
Yeah,
which you
yeah,
would maybe suspect the opposite, right?
they're pretty mild in terms of the joint, but there are people that exist that have those symptoms and they're really caught up with symmetry that anyway, the condylectomy jaw surgery route, I like that. But in terms of a bone scan active person or a superimposition change over the course of the year, condylectomy with jaw surgery on either variants or the any of the three variants, I favor.
Do you have concerns about I guess, reactivation, or maybe the growth process is arrested, but in the future, maybe it will not be? Is your decision that cut and dry? I've, as best I can determine with the information I have, this is not currently active. So orthognathic surgery alone is an option. Let's say they
Yes.
have that's truly your black and white there. I don't see signs of growth. I'm just going to treat it orthognatically. I
Oh,
see signs of growth. I'm doing condylectomy with orthognathic surgery.
no, I just the additional bit of how they're doing with their joint and why they're doing the surgery. So,
Okay.
because I mean, um, like a hemimandibular hyperplasia case, a big condyle that doesn't match the fossa, has an irregular contour. They have some TMJ symptoms and they really want to sort out the asymmetry. Doing a condylectomy is solid. I I'm much more a fan of condylectomy these days since the juggernauts existed,
Yeah.
than I was prior to that. So
Topic for another day. We should add that to the list.
yeah, we should. But anyway, without getting in there, let's just say positive bone scan, you want to do condylectomy. Do you either just do the condylectomy and see how their occlusion ends up and then do jaw surgery, or do you just do the combination of the two?
Oh, I would prefer to do it all at once.
Yeah.
I mean, I think that's better for the patient in totality. Trying to do it at one time and save them multiple recoveries and
I think
ordeals.
I think the paper that you had referenced a little bit ago about doing a computer guided condylectomy to avoid the idea of jaw surgery seems a little magical. Because in practice, it is a three-dimensional asymmetry, and while not everyone's doing it for face change, almost everyone who's talking to you about jaw surgery wants symmetry, or it wants to be as symmetric as can be.
So
Like having a yaw discrepancy in the maxilla or a cant or something seems good reason to do some jaw surgery. So
yeah, I mean, I think the argument for their paper, the one that specifically that I read was, well, let's describe it for the listeners. So it was a paper that advocated for using either a single cutting guide or two, depending on the morphology of the condyle, because as you brought up when we discussed it, oftentimes it's difficult to have a guide that's useful medially, right? So you make one cut, or there's another place where your initial cutting guide doesn't necessarily help you, or you can't get access to. So what they were advocating for was an initial cutting guide when applicable, and then followed by another one to get medial or any other areas that were maybe.
yeah, I think I think what you're bringing up though brings up the idea of how does a condylectomy work, right? Because
Mhm.
I think this is actually important because I feel like you just talk over, hey, I do a condylectomy, and then you talk to someone and it's like, hey, how do you do it? Or in what way is it different in elongation versus hyperplasia patients? You know what I mean? Because
Yeah.
when I'm talking about condylectomy, what I mean is an open surgery on the affected joint, and so it's a preauricular incision, whatever your open access incision is. You get into the joint, spares the disc. Disc is, I still haven't seen a disc that's in bad shape in this scenario, by the way. But you spare the disc and then you get to the inferior joint space and you reduce the condylar head. In elongation, I don't know, I just reduced by 5 millimeters with hyperplasia or hypertrophy. I try to get as much symmetry as the other side. I plan that ahead of time. So I'd go 12, 13, 10, 8, whatever's necessary to improve symmetry. Because what happens at the condylar head affects the inferior border of the mandible. And through
So how are you doing that? Like, how are you
virtual
planning
planning,
out
yeah, virtual planning,
cutting guide, or just a model to mimic, or what are you doing?
old school caliper. Because I mean,
Okay.
with the imaging ahead of time, that shows you in the access to get to the joint biases your condylectomy, especially when it's big, by the way. Because I mean, if you're taking off a centimeter of condyle, it is hard to make a horizontal cut to that because you're
Yeah.
approaching it from above. And so, you basically have to like layer it. Like you take off, a half millim or half centimeter, and then you push up the condyle and then take out the other half centimeter. It's very easily leave a lip medially. I think the contour of the condylar head is important because they got to use that from now on. And
Hmm.
you don't want to worsen the joint. And so making sure the disc isn't beat up, making sure that the contour of the reduced condylar head is compatible with jaw movement, I think is the sneaky part of doing that procedure. Because I actually find that to be the second hardest part of those surgeries.
What's the
So,
first?
the unaffected side split, that thing's sneaky hard. Have
Okay.
just so understand, have you run into this frequently clinically, like managing these things?
No, no, handful.
Yeah, so I mean, because condylectomies, the problem is that the bone in the condyle is squishy, like it's not good. You do open fracture management. That's the problem, is that the quality of bone's not the best. And so smoothing it out and making the contour correct, I think is tricky. And getting the disc to wrap over that, um the anchoring of the disc to the condylar head. What I was referencing was this Juggernaut business. MyTech anchor is the alternative. I trained, and I think you trained the same way of just tying it to the lateral
Yeah,
capsule.
lateral capsule. Yeah.
The
Yep.
obvious problem with that is the condyle sags. Like you do the condylectomy, sequencing of this, by the way, you do the condylectomy first and then you do the jaw surgery. Condylectomy, the condyle is going to sag. And so you're not going to make up for that until you get to the mandibular osteotomy. And I just was having a hard time believing that the disc was really maintaining its correct position. So anyway, you do condylectomy and then jaw surgery. Jaw surgery, probably the way to customize jaw surgery in these situations is a topic for another day, but I think the whole mandible can be affected in his sneaky hard split.
Okay. All right. So you do that. I guess the other treatment options would be just orthodontic surgery alone. I think that's fairly self-explanatory, at least in concept.
Yeah.
Or, the other thing we were talking about and you touched on is proportional reduction of the condyle so that it removes the asymmetry
Yes.
in people that do not have a cant. And I think that was the distinction in the paper is
Yeah.
that was their
Sorry.
treatment algorithm. If there's no cant of the maxilla, that needs to be addressed anyways, and you have to change the occlusal plane of the mandible. Can you do a proportional reduction of the condyle that then allows correction of the malocclusion or the asymmetry? And that was
Yeah.
what they proposed,
And,
which seems like a little difficult to do.
yes. And that's what I would get at is I find I don't, because there's always inaccuracy in virtual planning itself, but also in the transfer of virtual planning to the real life world. And I don't think any number of cutting guides is going to reduce my concern that it's still inaccurate. I think the argument that if it is still inaccurate and you still need to do jaw surgery secondarily is fine. Um, just I honestly don't think I've met that many people that I could just treat with a condylectomy and even think that sometimes they're going to end up with the fine occlusion at the end. I don't know.
But I mean, what if it got it close and now they're in the realm of orthodontic correction or orthodontic and occlusal equilibration world? Like, what do you think about that? I mean, that might be reasonable, right?
Hypothetically, yes. It's just I don't know. Honestly, I just and I'm open to the idea of it and I like it. I feel like because I want to feel like I'm helping them out and fixing their problem. And people are really into not having a lot of surgery. And I want to feel like at least there's a 50-50 no more surgery, right? Like you feel like more likely than not there's no surgery here. But I don't know. I'm a
So
bit of a
I mean,
skeptic, but open to it.
yeah, yeah. So I mean, the argument here is more surgery being more definitive versus less surgery maybe, but you're not as definitive. And walking that line as always, I guess, right?
Yeah. Yeah, and I
Yeah.
mean
Or
when there's certainly people who show up in your TMJ practice, so for more of an internal derangement symptom, and less on the malocclusion, facial asymmetry side. So maybe that's a group that does better with just trimming off the top of the condo.
maybe. Maybe. All right. So we went through some stuff on diagnosis, treatment options, your preference. And the few that I have done what you're describing. But I too am intrigued by the idea of possibly just doing condylectomy. But I think the important thing there, if that subtlety has not reached the listening audience, is that you should have a very serious discussion with the patient that you may need more surgery. We may need to do jaw surgery if this alleged proportion condylectomy doesn't solve your malocclusion.
Um, I think this is somewhat related, and I feel like now is a good time to throw out a clinical tip because I don't know if
Okay.
anyone got any clinical tips yet. This is one that you probably, I don't know, I feel like I learned this one fellowship. I'm kind of embarrassed to say fellowship. This has to do with detecting maxillary midline discrepancies in people with mandibular asymmetry. You know this one?
Go on, and I'll tell you. I mean, it's not ringing a bell off the top of my head.
Because maxillary midlines often look better than what they really are because their mandible that's asymmetric is pulling their soft tissues off the midline. And so
Okay.
you clinically tell them to straighten their mandible out, which obviously people need a little guidance, but you straighten the mandible out to the face to see how far their midline's off.
Hmm. No, I'm not familiar with that. That's
Great
interesting.
trick, actually. That one, anyway, I definitely have been burned by I don't know, not not correcting the midline enough, let's say. And so from the clinical view of like, does this person really have any maxillary asymmetry? It isn't just canned, it's things like midline. And at least in my world, midlines that are off are a big deal. And so having them shift their mandible to where it's roughly in the middle of their face and seeing where their soft tissue goes to their maxillary midline is helpful. So you'll pick it up on 3D planning, but by the time you get to 3D planning, you've already made the decision to do condylectomy or double jaw condylectomy. And so I think in what we're talking about, which is, do they have other reasons to do jaw surgery than just the malocclusion from the overgrowth in the condyle? Uh, I feel like that was a little clinical tidbit that I wish I would have learned earlier.
Yeah, I like it. I like it. That's a good one. I like it. What else? Yeah, any
I
other
think
tidbits?
condylar hyperplasia people, I just think that like, um, I don't know, I just hear of it just being like, oh, I don't do TMJ surgery, so we're just going to let the condyle grow afterwards and manage it. Um, it's a relatively unusual group of patients, but I find them to be remarkably resilient for their condyle that you operate on. Like they seem to be good
What do
in
you mean by
terms of
that? Like
recovery.
they,
They're different
you mean like,
recovery than internal derangement recovery, right?
right. That was actually going to be one of my follow-up questions to you. Is a number of these that I've done, I have then left that geographic area where I did them. So my follow-up on them is limited to where I think my ability to answer this question is not great. So I would pose it to you is what is their TMJ function correspondingly afterwards? Is it pretty good? Is it limited? Obviously, there's going to be some patient variability and circumstance
Yeah, yeah.
variability
Because I mean,
there, but I mean,
they
are they
recover
going good?
differently than your jaw surgery recovery, right? Because of scar tissue within the joint. So you have to kind of rehab to translation and symmetric joint movement versus just, traditional jaw surgery rehabs, fairly symmetric. Tends to be more of a tendon rehab type of thing. But I think generally, and I go by people who I've done surgery on or people have come in. So this could obviously be incorrect, but I generally view this to be that people do well with that joint afterwards. So they kind of, it is a younger patient. It is, the joints are doing reasonably well going into surgery. And so maintaining their TMJ function afterwards seems to be the expected outcome.
When you see them for follow-up and you look at them and you say, okay, look, you're opening well, you got good symmetry, you've got a good occlusion. Do you ever say to the patient, hey, that dog will hunt?
I'm trying to learn a lot of the slogans. I feel like I learn a new one every time. The dog hunting one is another. Is that a Texas one or is that an Arizona one?
I just think it's a southern thing.
Southern.
Yeah, I think it's that
Southern
dog
people
will
are the
hunt.
best. Um,
Yeah.
so could you help me out with that one? I know of it, but I'm trying to understand it. Like
Basic premise is that trick's going to work or whatever you're doing, that's going to work.
that's gonna be
That's
fun.
the trick. You could maybe another one that would be a synonym would just be say that'll do or that'll work. That's the solution.
Got
That
it.
dog will hunt.
So you tell them that ahead of time. That's the solution. I mean,
No, well, maybe you could.
well,
I don't
because
know.
I think the purpose of doing it, which is to take away the source of any further growth, I feel very good about. And I don't even think you need to remove a centimeter for um I was there's this phase of life, I'll probably tell too many stories, but there's this phase of life where I was interested in removing enough condyle. And so I'd get people radio tag glucose in the pre-op area. They would go up to radiology, then come down to surgery. And then I would use a probe during surgery. So I would take off a condyle and then I would test, kind of like sentinel lymph node
Yeah.
for condylar hyperplasia. This is a described technique by another person. I read it and I'm like, hey, that sounds cool. For very practical reasons, I got away from it, but largely my main reason for it was I was still taking out as much condyle as I was otherwise. It was like this. I'm not removing less or more condyle. I'm removing basically the same amount.
Did you measure to like, did you do any measurements to determine what
Because it took
that
like,
tended to be?
I think I did 3 or 4 patients, and it ended up being roughly how much I would remove anyway, which in condylar hyperplasia, which was more on the hemimandibular hyperplasia side, I wanted to remove more anyway from my overall jaw symmetry standpoint.
Right.
And so I
Yeah. I mean,
feel good
I
about that being
was
a
gonna say,
like the dog hunting in terms of not growing any further after the fact. Developing internal derangement. In my mind, I feel like operating probably puts them at the same risk of not operating in terms of the joint for internal derangement. Does that make
okay.
sense? So I
Yeah,
feel like,
does to me. Yeah.
um,
Well, I mean, I guess, you mentioned a centimeter, and the number that came to my mind, I don't know where it came from, was that really it was about 5 millimeters, was kind of, I think, what
yeah,
I read somewhere is like the minimum.
sure.
But I mean, would you agree with the premise of that? We don't know. Like, I mean, have you read papers or you had cases where someone went in and removed a certain amount and then it kept growing? I'm sure they're out there. I mean, those cases have to exist. I mean, could you make the case that being in the joint and just doing something to the condyle is actually what stops the growth process and not actually the amount of
Yeah,
removal?
definitely. Yeah, I mean, because there's other things that are out there because this is definitely an area that there's not enough volume of patients to really definitively tell us what to do.
Right. Not enough dogs to
Um,
hunt, typically.
yeah, the dogs and hunting. My dog doesn't hunt at all. Hanging out with me. I mean, I guess hunts a little bit of like bunnies and whatnot, but you have bigger dogs though, right?
Yeah, well, one of them's a puppy and will be bigger. Golden
Huh.
retrievers.
Yeah,
They
but to get
do.
back for the condyle thing, I mean, I've seen like a ablation of growth centers, like
Hmm.
um whatever the technique, whether it's cautery or anyway, to stop the growth center after surgery. I think a surgical intervention will arrest growth in the condyle, and using an open surgery where you remove a portion of the condylar head seems. I don't know why I would get away from that. It seems to be a useful thing. I feel like the conventional wisdom on that's correct. So
Yeah, I mean, I think as is always the case, we are at the mercy of the quality and quantity of the information that we have. And with that information, I would tend to agree with you if you said, "Hey, what do we have the most evidence of being effective and makes a lot of sense?" It's doing the condylectomy with jaw surgery as being a
yeah,
very reproducible, predictable operation most of the time.
yeah. Yeah, so I would encourage people to have that on their possible interventions and um, nice addition to your orthognathic practice.
Okay. Um, what else? Anything else on this topic you want to hit on?
I think that's about it. I think when it comes to condylar hyperplasia, there's always lots to talk about with topics, but I feel like we did pretty good on it. We're getting sidetracked a little bit on the dog stuff, I think is that's my fault though, so sorry about that.
Yeah, well, what can you do?
Yeah.
Well, then I guess let's wrap it up and just say, as always, this has been another Down Fracture podcast, a podcast for talking jaws. Please email us with any questions, topics, case scenarios. Again, protect your patient information. Downfracturepodcast@gmail.com.
All right.
And then we'll maybe have to skip next week, it sounds
Next
like,
week's I
right?
think is a holiday, so week after. So
Okay.
talk to you in a couple
All
of weeks.
right.
All right,
All
man.
right. Sounds good.
See you.
Take care.